Good evening, everyone, and welcome to the 8th Board of Health meeting in 2021. Today is September 21, 2021. A nice reminder for everyone to please turn off your cell phones and mute all your electronic devices to prevent distractions. To establish a quorum, I'm going to call out names of board of members I see present. Please let me know if I accidentally leave out your name. I see Dr. Kent, Dr. Al-Sadi.
Present.
Dr. McMahon.
Present. Present.
Mr. John Latch. Mr. John Latch.
Present.
Dr. Michael McKinney. Dr.
Present.
Thank you. Anyone missing? Do we have any other board members that have not mentioned? At this point, I will call on other present to please very briefly introduce themselves.
Jennifer Green, Health Department Director.
Ashley Curtis, Deputy Health Director.
Thank you.
Katie York, Accountant.
Crystal Vincent, Director of Nursing.
Kelly Smith, Administrative Assistant.
Thank you. Anyone else? Thank you for taking time out of your busy schedule to attend today's meeting. Today's meeting will be very, very short, but before we start, let's take a moment of silence to reflect on wine and bring awareness to the present. Thank you. Please look at the agenda for today on page 1 of your packet. May I please have the first motion to approve the agenda?
I make a motion we approve.
Second?
Dr. McMahon, second.
All in favor?
Aye.
Thank you. I trust that you have had the opportunity to go through the minutes from the last meeting on August 17, 2021. You have that on pages 2 through 4 of your packets. Do I have a motion to approve?
Dr. McMahon, make a motion to approve the minutes.
Second?
Al-Sadi, second.
All in favor?
Aye.
Aye.
Thank you. So next on the agenda is the revision of the fee schedule. Mrs. Candy York, can you please present the revised fee schedule?
Yes, ma'am. In your packet, beginning on page 6, is a revision prepared of the fee schedule. DMA has approved increasing the fee schedule due to increased costs during the pandemic. The methodology that we had used in the past to review our fee schedule has always been based on the cost to perform the services, our costs to actually supply vaccines, or at a minimum, the Medicaid reimbursement rate. When they first increased the Medicaid rates, they did this as a temporary measure. They did this a little while back in the beginning of the pandemic. And each time it was released to us, it was like as a temporary change. So when we did the review for the fee schedule for the budget year, fiscal year 2022, we were under the impression this would be ending as of June 30th, 2021. And therefore, the rates would go back to what they were pre-pandemic increase. However, we have been informed that they are not going to be decreased, and there's no set target date where they will be. So in the past, following methodology and the recommendation from the state that your fees be at a minimum of the Medicaid reimbursement rate, we went through and reviewed all the fees and made a determination on which ones needed to be adjusted. On page 6, it begins with your dental services that we provide in child health, followed by vaccines. I will point out on page 6, the flu vaccines, because that's generally what we look at this time of the year normally. It is about code number CPT 90662, titled Flu Zone High Dose. That fee, we'll point out, is going to go from $50 to $62. A little bit farther down, the CPT code 90682, flu block, 50 to 64 years. It's going to increase from $45 to $62. And then followed by the flu quad preservative free, 36 month and up, 90686 is just increasing from $19 to $20. But I did want to point out those because those are our flu vaccines. On page 7 begins our lab services that we perform in our clinics at the health department. They're continued on page 8 as well. Also on page 9, and about halfway down page 10. On page 10 of the lab services, I did want to point out that we do have one new lab service we're asking to add to our fee schedule. It is titled COVID/flu/RSV, CPT code 87428. That is a test that we were performing in our clinics because it is one test that will check for all 3 of these viruses. So we did not have a fee set, and the Medicaid reimbursement rate for that service is $82. So we would like to add that service. Then begins our medical services on page 10, the bottom part, and goes into page 11. At the bottom of the page 11, you also see a new fee that we'd like to add. It is a smoking cessation counseling greater than 10 minutes. We are beginning that service. We had the 3 to 10 minute already in our fee schedule, but we do want to add the greater than 10 minute counseling that our providers can offer in our child health, well, any of our clinics, but especially in our child health and maternal health clinics. If they offer that counseling to try to get the resources to the patient so that they can get all the help they can to stop smoking, that we can get reimbursed through Medicaid for that as well and other private insurances. So we're wanting to add that service of 99407, and the reimbursement rate is $34. And then finally on page 12, for environmental health, we have our rabies vaccination, which is what's performed for our cats and dogs. It's usually held every fall and spring. We do the outreach clinics. We're actually requesting to decrease our fee from $10 to $5 to also be in line with what Animal Services changed their fee to at the beginning of July of this year. We were not aware that they actually decreased their costs, but they're wanting to make it more attainable for citizens to get their animals this vaccine. And the cost to do that service is around the $5 mark. And it's also in line with surrounding counties, the cost that they actually charge to citizens. And I just want to remind you, of course, that all of the services that we perform in the clinics are subject to the sliding scale fee. So although we're increasing the rates, if a patient comes in, they can slide down to 0 and still have no charge for the services they receive. Of course, and then based on the sliding scale, it could be 10% of the charge, 20%. So although we're increasing the charge, it's not hundreds of dollars increase to the patients So say, for instance, if the service was $25 and we increase it to $30, instead of them, they were at a 10% sliding scale fee. Instead of them paying $2.50, they would be charged $3. So that's something to keep in mind when reviewing these fees. And I'll be happy to answer any questions about any of the fees that I presented to you.
Thank you, Mrs. York. Does anyone have any question or questions for Mrs. York on the fee schedule? Comments, please.
I have a question not specific to, Doctor, I have a question not specific to the fee, but I was just curious, the COVID flu RSV test, is that a test that distinguishes if someone has cold or flu-like symptoms between those three different viruses?
Yes, so we'll be able to tell if it's, we'll test for all, it's a testing for all three of them in one test. So we'll be able to differentiate.
This is Dr. Kearney. I have a question. Are they currently charged for the testing for COVID now?
No, ma'am. So we don't bill for that. Well, let me take that back. So the patient, we are not charging patients for a COVID test. No. So if they are uninsured, they don't get a cost, and if they do have insurance, there's no cost to the patient at all. We're able to submit some claims through the HRSA portal, and then we can bill insurance as well. But if you are uninsured or you can't pay or you don't present your insurance, we are not charging for a COVID. The patient doesn't pay for a COVID test regardless of their insurance status.
Would that be the same process for the combined test?
Correct. So we wouldn't charge them for that test. So if they have the combined test, that would be subject to the sliding scale fee. But we wouldn't charge we are not able to, through our grant agreement, to charge the patient for a COVID test. And Candy, if you have anything to add to that.
Okay.
Yeah,
I
and
was
so
wondering, since it was combined tests, was there a difference?
that's usually done on our child health clinic. And from what I was from the lab manager, is that keeps the patient from having to get swabbed multiple times. So if they check them, they come in, they think they might just have the flu. So they do this test. So most of those patients we see in child health, they're going to come in, they're either going to have Medicaid, which we could bill this for. They're going to be sliding scale. A lot of times, 99% of the time is going to slide down to 0. They're going to have North Carolina Health Choice, or they may have private insurance. So we haven't had a situation, and so it was something that we had discussed that since it is checking for the COVID, that we wouldn't charge for that particular test, even if the patient has a sliding scale fee, because COVID's included.
Any more questions? Thank you very much, Mrs. York. May I please have the first motion to approve the revised fee schedule?
Dr. McMahon, I make a motion to approve the revised fee schedule.
Thank you. Second?
Dr. Dean, second.
All in favor?
Aye.
Thank you very much. All in favor?
Aye.
Aye.
Thank you very much. Mrs. Candy York, can you please also brief us on the administrative fee for the flu vaccine?
Yes, ma'am. We would like to request again that we waive the administration fee for anyone coming to the health department to receive the flu vaccine. Therefore, they would only get charged the fees that we were discussing earlier when they presented. And of course, that would be billed to their insurance, if they have insurance, or of course Medicaid. But if they're a self-pay patient and they come in, and they would only pay that particular vaccine cost. And that would actually, the cost of the vaccine would actually absorb the cost of the actual purchase of the vaccine made by us for private pay patients. We've done that in the past couple of years, and so we just want to continue with waiving that extra charge.
Thank you, makes sense. Any questions, please, on the administrative fee for flu? Comments, please, from the board members.
I have a question. How many people would that apply to? I mean, would that make a serious dent in the revenue?
I haven't checked it for last year to see, as I know, as after we got through the big burst of flu vaccine. But when I did last year, it was only around $4,000 of lost revenue.
Does that answer your question?
Yes.
Thank you. Any more comments, any questions? May I please have the first motion to approve a waiver of the administrative fee?
Dr. Kearney, motion to approve.
Second,
Dr. McMahon, second.
all in favor?
Aye.
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 Thank you. Mrs. Candy York, can you please again update us on the billing guide?
Yes, ma'am. In your packet, you were provided a copy of the billing guide, and I've made just a few adjustments for this fiscal year. On page 8, on the grid, where states whether or not you have to be a Cumberland County resident to receive services, there was a change in the WIC program. Years ago, before Crossroads came on board, the women's, infants, and children's, you had to be a Cumberland County resident, but now you can be a resident anywhere in North Carolina and still come to Cumberland County to receive your WIC services. So I've made that change to move it up under county residency not required. On page 10, in the section where how is the fee paid, where it says the Cumberland County Health Department currently contracts with. At that time, we had Medicaid, Medicare, and Blue Cross Blue Shield. I've added that we also are in network with United Healthcare, TRICARE East, and also MedCost. And that is updated throughout anywhere we talk about in-network insurances. That's updated throughout the manual. On page 11, for immunizations, previously we did have a statement here that came from the state that there was a residency requirement for immunization clinic, but I've taken that out because there is no residency requirement for immunizations. You can come to our clinic for any immunization throughout the state, anywhere you're from the state. And then even out of state, if you're military related, we'll have folks present like that. Then on page 18, my pages. We just had to add some income sources that we have to consider when we're doing the sliding scale. So down toward the bottom of number 4, I have added income taxes. We use the adjusted gross income. Bank statements, if it shows a deposit is for SSI, it's a governmental deposit monthly. And then family planning clinic, people citizens that come for services there, they can self-declare if they're in high school or if they're 22 and under and they have college ID or proof of registration at college. Other than that, they have to present income for us to adjust their pay on the sliding scale fee. And then that is all that I have added to that billing manual. But I'll be happy to answer any questions about those changes or anything else contained in the manual.
Thank you, Mrs. York.
Thank
If you have questions, please, for Mrs. York on the billing guide updates or any comments? In that case, may I please have the first motion to approve the billing guide updates?
Dr. Kearney, I approve the billing guide.
Thank you. Second? Have a second motion, please, to approve the billing guide updates.
Second.
Mr. Lynch, I second.
Thank you. All in favor?
Aye.
Thank you very much. Moving on to item 3 on the agenda. The floor is now open for public comments, please. If none from the public, we will close the floor for public comments at this time. And I will call again on Mrs. Candy York to please present the financial reports.
Yes, ma'am. Beginning on page 13 of your packet is your statement of revenues and expenditures for the month ending August 31st, 2021. At the close of the month, our revenues exceeded our expenditures by $185,707.31. On page 14 is a report of expenditures by program. Beginning on page 15 is your revenue report. Page 15 reflects your state and federal allocations, collections, and also grant funds. Page 16 is Medicaid and fee revenue. And also it reflects the county funds that have been allocated to our programs through August 31st as well. On page 17, we have the accounts receivable report broken down by program and payer source. And then finally on page 18 is our private pay, AR, broken down by program. And if there's any questions, I'll be happy to answer them.
Thank you, Mrs. York. Do we have any questions, please, on the financial reports? Or comments, please? Thank you, Mrs. York. May I please call on Miss Hannah Prentice-John to please update us on the Fort Bragg Community Survey?
Sure. Good evening.
Good evening.
And what would be the best way to advance the slide? Should I just say next?
Yes, ma'am.
Okay, perfect. Thank you. Well, thanks everybody for having me this evening. My name's Hannah Prentice-Dunn, and I'm a project manager with the UNC Lineberger Comprehensive Cancer Center. And I've been working closely with the Fort Bragg Department of Public Health, as well as the Cumberland County Department of Public Health for the last few years on a host of public health projects. And one of those big public health projects that we've done in the last year is a Fort Bragg community survey. And so we're going to brief you all this evening on some of those results. Next slide. So as you can see here, the community survey that we worked on in partnership with Fort Bragg and the Cumberland County Department of Public Health covered a wide range of topics. And this community survey was the idea of the Fort Bragg Department of Public Health Director, Colonel Cheryl Bedno, last year. So in the summer of 2020, our group at UNC worked closely with Colonel Bedno on Fort Bragg to develop the survey questions and work with points of contact on Fort Bragg and in Cumberland County to develop these items. So we have a whole lot of data, but for the sake of this evening, I'm just going to be covering the topics that you see the icons in blue. So these 4 or 5 topics here. Next slide. This gives you more sense of the timeline of this Fort Bragg community survey. This survey is really intended to assess the quality of life needs for Fort Bragg soldiers and families. We know Fort Bragg is the largest military installation by population in the U.S., and we know that about 55,000 soldiers are stationed in and around Fort Bragg. And when you think about family members, that number grows to about 200,000, many of which are living in Cumberland County. So these survey results that we received are really relevant to Cumberland County, given the high number of soldiers and families that you all have in your borders and that you all serve every day. So the results of this community survey will inform Fort Bragg's own programs and services over the next 3 to 5 years. And we disseminated this to soldiers, family members, anyone in the Fort Bragg 8-county region. We drafted the questions in summer of 2020. It took us a little bit to get approvals on Fort Bragg. Getting approvals in the military can be a little bit slow, but we did get approvals from the leadership on Fort Bragg, Major General Kraft, in April 2021, and then in partnership with Dr. Green and Ashley Curtis from Cumberland County, we disseminated the survey in April and May. And then we had a UNC graduate student analyze the results this summer, and that's what I'll share with you now. Next slide. We were thrilled at the response that we got to the community survey. We provided an incentive raffle for the survey, but we did get about 3,300 responses to it, and this was more than double the response that previous community surveys had received. So that is a really nice sample given a military survey. Here you can see about the breakdown of relationship to Fort Bragg. So about 23% of service members, of survey respondents were service members, and almost 40% were family of service members. And so these numbers really reflect what we know about the population in the Fort Bragg community. Next slide. So I'll brief on several different health topics and the results that we saw. The first is tobacco use and vaping. Next slide. So we did ask about tobacco use among individuals and if they use tobacco or vaping products, but we also wanted to ask about visibility of tobacco and vaping. And one of these reasons is we're hoping to work on some smoke-free and tobacco-free policies on base. And we did see that tobacco products and vaping are quite visible on base. So the majority of community members saw both tobacco products and vaping every day on base, and many saw it multiple times a day. So this really comes into play when we think about Fort Bragg's own tobacco-free policy. Next slide. Here you can see the national average of tobacco use in the US. That's the orange bar in this graph. And about 1 in 5 US adults use tobacco. And what we saw from this survey were much higher rates of tobacco use on Fort Bragg. I do want to give the caveat that this is not a scientific representative sample that we have, but it is quite a large sample. And so I know Lieutenant Colonel Pierce, the current health director on Fort Bragg, is taking these numbers seriously. And we definitely wanted to share this with you to show the extremely high rates of tobacco use that we're seeing on Fort Bragg. Next slide. And this drills down more into that tobacco use data. So almost half of all respondents to the survey are using some form of tobacco. That number goes up to almost 3 in 4 soldiers that live in the barracks are using tobacco products. And more than half of responding 19 to 39-year-olds responding to the survey are using tobacco products. So incredibly high endemic rates of tobacco use. Next slide. We also asked about when people started to use tobacco, and we heard that 1/3 of people who use tobacco started after joining or working in the military community, and about 1/4 started after they joined Fort Bragg specifically. This is very rare to see in the US population, and it speaks to that culture of tobacco use that we hear about in the military. Next slide. While there is a lot of tobacco use, which I just spent 5 slides covering, I think it's really important to note that privately, people are trying to quit. So while there is this high rate of initiation of tobacco use, high visibility of tobacco use, privately, soldiers and family members are really trying to quit, and the majority are accessing resources to quit. So we have some really good ideas on Fort Bragg for how we can help Fort Bragg soldiers and family members quit tobacco. Next slide. So current projects to address these needs that we found, Dr. Green and Ashley Curtis were actually instrumental in pulling in a 5-year CDC grant for our partnership with UNC, Fort Bragg, and Cumberland County to work on reducing the tobacco use rate on Fort Bragg. So we're hoping to reduce the tobacco use rate to about 17% of all soldiers by 2025. And we're working with the Director of Public Health on Fort Bragg on a host of evidence-based strategies listed here on this slide to combat tobacco use. Next slide. WIC services were a really striking finding from our community survey. Next slide. We saw that Fort Bragg has lots of young families, which is probably no surprise to you all. Of survey respondents who answered the survey, we found that 41% were pregnant, breastfeeding, or had a child under age 5. And of those, almost 80% were currently using WIC services. And that's about 30% higher, 30 percentage points higher than typical North Carolinians. So there is a very high usage rate of WIC services on and around Fort Bragg. Next slide. We did ask about where the survey respondents were living and those who were accessing WIC services. And people are accessing WIC services in the 8-county region surrounding Fort Bragg. So here you can just see that there are lots of people spread out around Fort Bragg, and many are using WIC services. Next slide. Among those currently using WIC services, about 70% said they would likely use WIC services if they were offered on base. So we're trying to improve access to WIC services if we can. And of those interested in using WIC services, about 3/4 think it would be more convenient on base if they chose to enroll in WIC services. Next slide. We did ask about barriers here, and we saw barriers as don't have time to go to an appointment, too difficult, it's too hard to understand the process, and some didn't have reliable transportation. Next slide. So to address these needs, we're working very closely with the garrison commander, with Dr. Green and Cumberland County to actually bring a WIC office onto base at least 2 to 3 times per week to combat those barriers of transportation and maybe the difficulty of making an appointment. And those talks are actually ongoing right now and spurred and opened because of this community survey. Next slide. We were really struck by the amount of food insecurity that we saw from this survey. Next slide. We did see that about 64% of respondents indicated that they had experienced food insecurity over the last year. We did also ask about worry about food insecurity, and it was about the same rate, but it's really striking, and I know Lieutenant Colonel Pierce, the health director on Fort Bragg, was really struck by this data at the prevalence of food insecurity that soldiers and families were experiencing. Next slide. People were more likely to experience food insecurity if they lived in the barracks, which we have shared with different office leads on Fort Bragg. Also more likely if they lived in households with children under 18 years old. Next slide. We did ask about just typical food access for soldiers before COVID-19, because we know the last year and a half have not been normal for everybody. And we did find that the DFAC, or the Dining Services Food Truck, was wildly popular among soldiers. We also saw that fast food and other food trucks run by AFEs or the exchange unit on base were very popular. So when we think about healthy foods and where to put them, these are good ideas. Next slide. We did also ask about non-service member food sources, so family members where they're getting their food before COVID-19. And the commissary was very popular, in addition to restaurants and fast food restaurants off post. Next slide. We did ask about healthy foods and if people were interested in eating healthier, and we did find among soldiers that over half are interested in eating healthier than they do now. And we asked about different perceptions about food on base, and we did find that people feel like it's more accessible to get unhealthy foods on base. So we have shared this with lots of different food leaders on base, and we have really emphasized that, like in our civilian life, healthy food options are usually there, but sometimes it's a matter of marketing them or placing them in places where people are more likely to pick them up or purchase them. Next slide. We did also hear that non-service members are interested in eating healthier as well, and here are several different perceptions that we measured. Next slide. The top barriers to eating healthy on post were about the same for service members and all respondents, so including family members, and they include the quality of healthy options and the price and availability of healthy options. Next slide. So what are we doing about this data? We're definitely working and meeting with the dining facilities, the exchanges, and also the family and MWR departments on base to help them improve their healthy food offerings in their locations. And everybody is quite interested in working on this, especially on promotions. So they want their own healthy food options to sell, and we're testing out some geofencing and beacon technology to actually send push text notifications to soldiers and people on Fort Bragg to maybe pick up that apple when they go to check out and pay for their meal, or to consider a healthy option when they're inside that food environment. We're also working with base leaders on some food truck pilots to just test out some healthy items and see how they sell. Next slide. With transportation, we heard that well-maintained sidewalks, trails, and bike lanes would promote physical activity on post. Next slide. And we also asked about Fort Bragg shuttle use. So Fort Bragg does have a shuttle, and we asked what people would need in order to use it more. more than half said that having an app would help them use the bus more to know where the bus was at any time, and also having more convenient stops. Next slide. We also asked about a fast bus between Fort Bragg and Fayetteville, and more than half of respondents said that a fast express bus that goes from the South PX into Fayetteville would be desirable, and most thought it would be nice to have an express bus route from Fort Bragg for special events in Fayetteville as well. So we have shared this information with Mr. Randy Hume from the Transportation Department in Cumberland County. Next slide. We also asked where people on base would want to go, and these are the locations that we heard of people wanting to use the fast bus and where they would like to go off base. And again, we've shared this with contacts at the Fayetteville Transportation Department. Next slide. So in response to these needs, we are really trying to get the Fort Bragg Transportation Department and the Fayetteville Transportation Department to work together on some of this. And we know that the Fayetteville Transportation Department is assembling a steering committee to inform its transportation development plan. And the garrison commander on Fort Bragg is actually looking for somebody to put on that steering committee. So we see an interest on Fort Bragg and in Fayetteville to work together on these transportation issues, and we're making those connections. Next slide. We asked about vaccinations. Next slide. And thankfully, we heard that more than 4 in 5 respondents in the Fort Bragg community agreed that vaccines are important, safe, and effective, and about 80% of respondents with kids have or plan to vaccinate their children against HPV and cervical cancers. Next slide. And this is great. We've been working with the Medical One-Stop Clinic on Fort Bragg to incorporate HPV vaccinations into standard in-processing for soldiers aged 18 to 26. So this is a pilot quality improvement initiative that started in April of this year and has been ongoing, and hundreds of soldiers have accepted the HPV vaccine at this point. So we're glad to hear that there is some positive feelings about the HPV vaccine. Next slide. And last but not least, we asked about the COVID-19 pandemic. Next slide. We asked about news outlets and where people got their information. And this is some of the news sources that people look at. Most common is local news outlets, followed by national news outlets and the Center for Disease Control. Next slide. And we did ask about vaccination for COVID-19. For this survey, we heard that almost 90% of respondents would be willing to get a vaccine to protect against COVID-19. And I think still relevant to us today is reasons for not receiving the COVID-19 vaccine. So you can see the top reasons listed here: concerns about safety and side effects, belief that vaccines are part of government conspiracy, or concern that the vaccines would not work. Next slide. So I know that was a whole lot of information that I covered, and I'm happy to take any questions about the survey itself or about any of the health topics that I covered.
I just want to queue up for ahead of the questions. One of the reasons we had Hannah come today is because in October, our health education team, along with Hpv Valley and the health system, are going to be holding the stakeholder meetings, and that's why we needed Hannah to come tonight ahead of those meetings, so that this board had an opportunity to review those findings, and then during those stakeholder meetings, they'll review the results of the community health assessment that the county did, and then be able to take this data along with that and develop those into community health improvement plans as a part of our accreditation requirement. So really putting together both of those pieces. And Hannah, if you are okay, we will share the slides out with our board. And then once the full data, there are several more data points that we didn't have time to share tonight, but we'll share out the full set, not the raw data, but the presentation with you so that you'll have that.
Yeah, that's great. And I do want to mention that we did see this incredible response to the survey, and I think a huge reason for that is the effort that Cumberland County put into promoting the survey. So we know that Cumberland County paid for social media posts, helped print out flyers and deliver them to Fort Bragg. So this really was a success story in collaboration between Fort Bragg, Cumberland County, and UNC.
Thank you very much, Ms. Hannah Prentice-Dunn. That was very informative and very educative. And also thank you to Dr. Green and Ms. Ashley Curtis and the Department of Public Health, Cumberland County, for your roles in the survey and also for facilitating the 5-year CDC fund. Do we have any questions, comments for Ms. Hannah Prentice-Dunn? Comments, please, questions? Thank you very much.
Dr. Kearney, I wanted to share that I thought the information was extremely informative, and especially the information on the tobacco use and the vaping. That was quite an eye-opener, and thank you so much for sharing.
Absolutely, thank you.
That was very educative. Thank you so much once more. I will now call on Dr. Jennifer Green to please present the director's updates.
Good evening, everyone. I'll keep my updates brief. Just want to make sure the board has an update on COVID. So in the last, in total, we've had 40,000, almost 41,000 cases. We put this data down yesterday. In the last week, we've had 778 cases and 1,800, almost 1,900 cases in the last 2 weeks. So we're seeing just a little bit of a decline. So that's a little bit of glimmer of hope in our declines in cases. Our case positivity rate has dropped off just a little bit. Last meeting, we were at about 15%, 16%, and this month we're at about 12% in our 2-week or our 7-day average. But still much higher than we want it to be. We want that number to be 5%. As you can see from the map on the screen, from the CDC's alert system, the entire state, including Cumberland County, is in red. And then we've had 409 deaths since the beginning of the pandemic. This is our testing data. So this looks at over time since the beginning of, from January 2020, the number of tests that we performed week over week. So you can see it kind of follows the trends of the cases. And here on the next slide, we continue to see a number of an increase in testing. On the top graph here is our 7-day moving average in our case positivity rate. So that sort of aligned with, if we overlaid this top chart with the last slide, as we increase testing, we increase our case positivity rate. This one is from the CDC's data tracker. So we're seeing just a little bit of maybe a decline and leveling off of our case positivity rate. But again, far too high. In terms of the bottom green line is our trend data, again, from the CDC's data tracker. So it lags behind us a couple of days. We're starting to see just a little bit of a drop off in cases over the last week or so. So we hope to see those trends come down, but we of course need them to come down much faster than they already are. On the next slide, we have brought back our color slides where we have all the breakdown by race, ethnicity. And so this chart shows our cases since March over time. So you can see the current spike that we're in at the very right-hand side of the graph. And then the breakdown by race, ethnicity. So the purple, darker purple color are those that identify as white. The medium blue shade is those that identify as African American, make up about 38% of our cases. African Americans make up about 41% of our population. So just actually a little bit underrepresented there. But again, we still see wide disparities by race on our COVID cases. On the next slide, we have the breakdown by age. And so in the purple is where we continue to see the largest percentage of our cases among our 25 to 49-year-olds. But we are seeing an increase, and this is statewide and national, among our younger people. That's the fastest growing group, of course, because that's the group that is largely unvaccinated. Overall, because this looks at numbers throughout the course of the pandemic, we haven't seen that number shift overall quite very much. Our 25 to 49 still make up the majority of our cases, but the most recent increases, we're seeing a larger increase among our younger population in the last, during this most recent surge of cases. On the next slide, just a quick update about testing. We do still have the at-home test kits available for pickup at the health department while supplies last. With an emphasis on the while supplies last, we tend to run out each week, so that we encourage the public to come and get that PCR test. You get it, you can send it out and get your results back in just a couple of days. We're also anticipating getting some of the at-home rapid tests, and we're going to work with some high-risk community partners to get those out to those agencies. And then we have ongoing testing at the health department on Monday, Wednesday, Fridays, 9 a.m. to 4 p.m. For PCR testing. And so we kicked that off in August, and that's been going well. No appointment needed there. This is our vaccination data. So on the right-hand side of the screen, you can see the percentages of those that are fully vaccinated. So in the total population, we're almost at 52% of our total population vaccinated. Of course, we want that number to be much higher. Those metrics don't include people that does include individuals that are not yet eligible to be vaccinated. So if you look at the breakdown just for individuals that are over the age of 12 and individuals that are over the 18, those percentage points go up quite a bit into the 60s. But again, we need those numbers to be much higher in the 80s and the 90s to really see some drop in our case count. And then, of course, I always highlight our 65 and older group because 94% of them have received at least one dose, and 80+% have received are fully vaccinated, and which is, of course, why we're seeing a decline in the number of cases among those age groups. This is some data I just wanted to highlight. I'm not sure it was available at our last meeting. The state health department has a report that we'll send out to you, and they really week over week, each Thursday, they pull down the data about the cases among vaccinated individuals and the data cases among unvaccinated individuals, because we get a lot of questions about breakthrough cases. So each week they give a weekly update on the risk or the attack rate for those that are vaccinated versus unvaccinated. So for the week ending, it hasn't been updated for this week, so the week prior, unvaccinated individuals were more than 4 times or 419% more likely to get COVID as vaccinated individuals, and unvaccinated individuals were 13, almost 14 times as likely to die from COVID as vaccinated individuals. So really stark differences. We needed more data to make the case. On the next slide, this is a slide that we had last time, so I just want to remind the group that we do currently are vaccinating individuals with additional doses for those that are immune compromised, and we'll continue to do that. It's self-attestation. They just need to show up to the health department for additional doses for both Moderna and Pfizer. The next slide, one more slide, Kelly. Thank you. So last Friday, the CDC's advisory committee met to determine, make a decision about booster doses. So the vote was to authorize booster doses under an emergency use authorization for those that are 65 and older, and for those that are high risk or have high risk conditions. So we still have a couple more steps before we can begin. As part of our provider agreement, we need to wait for the ACIP committee, and we need to wait for the CDC's director sign off. So their meeting to consider will be this Wednesday and Thursday. So if approved, we'll get more clinical guidance, meaning we'll understand better what high risk means. So we won't begin before Friday. I anticipate that it may even be later than Friday, depending on how late in the day that advisory committee meeting is and how quickly we can write our standing orders and get ready to go. But certainly no sooner than Friday, but it may be later in the week, maybe next week. This is just for Pfizer, so no boosters for Moderna and J&J yet, although we anticipate that that will come in the coming weeks, but just not yet. And then one more slide. Yep, so vaccines for younger children. Yesterday, the Pfizer released data about vaccinating younger children ages 5 to 11. What we are hearing is that Pfizer is planning to submit that application to the FDA by the end of September, and then it will go through the same process again. The FDA will review, authorize, likely under an emergency use authorization. It will go to the CDC's advisory committee, and then it will go to the CDC director, and then we will be able to begin vaccinating. So I anticipate that will be, those meetings aren't even scheduled yet, so it will be a couple more weeks before we actually see that pan out. And then we do anticipate that we'll have vaccines for children under the age of 5 at some point too. And then just a few listing of a few places that we've been over the last month: Fayetteville Tech, Methodist, the City of Fayetteville, PwC, working really closely with Cumberland HealthNet and the team at Healthier Together to provide vaccinations in a variety of places, and making sure that we have vaccines available at our county libraries on Saturdays on a rotating basis. And I think that's all I have. If there's any questions, I'm happy to answer those. The other piece we wanted to remind folks about is that we do, please, if you have recommendations, thank you, Dr. McMahon, for the board vacancies, please send those to Kelly. We have four board vacancies. And so in terms of timeline, we really need to get this in ASAP so that this board has time to review them in November, vote on them in December so they can be seated in time for your Board of Health retreat in January. And really the commissioners need to vote on them in December so they have time to participate in the board retreat in January. So the sooner we have those recommendations, as we get them, we'll come back to the board so you guys can review them and begin voting on those vacancies. So we've got 4 vacancies. One of them is a commissioner vacancy. Dr. Council will be rolling off the board. Her term is ending. And so we'll get one of those will automatically be replaced by a different commissioner, but we have 3 others that we need to fill. So if you have recommendations, if you want to get them to Kelly, there's an application to fill out. I can help connect them to that online application. That's a reminder that is coming up. And that's all I have, Dr. Ojo.
Thank you very, very much. Any questions or comments, please, for Dr. Green on the COVID updates?
Dr. Green, I have a question. So when you test positive, this is from a employee, when you test positive from COVID, how long can the test be positive?
Yeah, so that's a good question. The answer is we don't have the exact time. Like if 3 months and 2 days have passed, we don't know the exact time. The estimate is about 90 days. So if you, and the way you sort of define it, a reinfection would be if you test positive today, it's been more than 90 days, and then somewhere in there you have a negative test, and then you test positive again, we would say that is a reinfection. But people can test positive for weeks and weeks and weeks, and we've seen that happen, which is why we don't recommend a negative test result to come out to work. We know people can test positive long after they are no longer infectious. So it could be up even 90 days later, people are still testing positive.
And follow up to that, so we're not recommending testing or retesting, but when should people return to work?
Oh, right. So we use a time-based strategy. So probably the time is running together about 1.5 years ago. We stopped using a negative test result to return to work, and we use a time-based strategy. So if you are sort of a general case, right, with fairly mild symptoms, we use a 10-day time marker. So 10 days from your symptom onset, or 10 days if you are asymptomatic from the day that you got your swab done. We use that time frame to return to work. If you were hospitalized or have some other, maybe you got monoclonal antibody therapy or had something else going on, we would maybe extend that time to return to work. and our case investigators and our hospital staff would work with you on an into isolation date if you had severe COVID that put you in the hospital.
Thank you.
Thank you. Any more questions for Dr. Green? Especially on the Board of Health 2022 vacancies?
I have a question. Who's the third person that's supposed to come off the board? I thought it was just Miss Council, Dr. Council, and myself.
Yes, Miss Stacy Cox is leaving us. She is moving, so she's gonna not be able to renew her board because she won't be in Cumberland County anymore. So we are so appreciative of her service, but she won't be able to continue because she'll be moving out of the state.
Any other questions? Thank you very much, Dr. Green. Please review the membership attendance roster on page 19 and communicate any discrepancies to Ms. Kelly. The floor is now open for comments, please, from board members. Do we have any comments, please, for board members? Thank you very much all for attending today's meeting. Please mark your calendar for the next regular board meeting on October 19, 2021 at 6 p.m. And if there is any item or items that you would love to be included on the next agenda, please let us know ahead of time. May I please have the motion to adjourn today's meeting?
This is Dr. Conrad, motion to adjourn.
Dr. McMahon, second.
Make a motion to adjourn.
All in favor?
Aye.
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 Any more?
Aye.
Safe. Bye.
Have a good night.